State regulation or state licensing for medical professions is a 19th century solution to a 21st century problem. Hey there, Rafi Salazar from Rehab U Practice Solutions. This week we're talking about state licensure of healthcare professionals. Is it something that we still need to be thinking about? Is it something we still need to do? Or would healthcare be better as an industry if state licensure of healthcare professions went away? Let's dive right in. Okay, this episode is basically pulling straight from a post that I did on LinkedIn a while back. It got a lot of engagement, a lot of comments, a lot of argumentation and debate back and forth about whether or not state licensure is something that's still relevant, that we should still be our main mode of protecting the public, because that's the mandate for those unaware. The mandate of state medical boards and licensing boards is to protect the public. So the question is that something that is necessary now, not protecting the public, but is the mechanism of doing that through state licensure still the best way to do it? I tend to think, now I sat just from a historical context or like understanding where I'm coming from on this subject, I sat on a state board for occupational therapy from either 2014 or 2015 all the way until this year, 2025. So about 9 or 10 years, give or take. And I've also sat on the state or the national board for occupational therapy here in the U.S. So I've seen the kind of the development over the last decade or so of regulatory patterns or discussions in the regulatory sphere in healthcare from both a state level and a national level. What's the best way to do it? What's effective? What's not effective? What are the challenges in regulating a healthcare profession nationally, internationally, you name it? So let's dive right in. I'm going to go ahead and be just very transparent up front and say that I tend to believe, and I've always thought, that anything we can do to decrease barriers to entry to any field is going to be better for the field long term. Does it mean that imposes greater risk? Yes. And that's something that as a society, maybe we can have a discussion about, right? Is it worth limiting some of our potential advancements in healthcare in order to quote unquote keep people safe or more safe, right? But as I dig into this, maybe we'll get more into the weeds and the details about whether or not that's a real real concern that we need to have. So let me just go back. I'll read some of this post and then I'll hit it point by point. So I start off the post by saying state licensing for healthcare professionals could go away, and healthcare may actually benefit from that move. Now, I say this after being on a state licensing board member for about 8 years or so, 9 years. And here's why I think that state licensing could go away or should go away. The main problem with it, in my mind, having been somebody that's sitting on a board and having discussions about regulations and applications and new licensure requirements, et cetera, is that state regulation or state licensing for medical professions is a 19th century solution to a 21st century problem. And what do I mean by that? Specifically in the world of healthcare technology, of tech-enabled care, telehealth is kind of the big one that's thrown around, but I really mean the ability to deliver services virtually. When I was consulting with a state department of health, behavioral health and developmental disabilities, I called it, when I developed the process and the frameworks for virtual service delivery, that's what I called it. It's virtual service delivery, because I don't mean just telehealth where you're getting on a synchronous Zoom call or video call with your healthcare provider. I'm talking about all of the ways that technology allows us to communicate and interact synchronously, asynchronously, audio only, video, text, all of that in my mind devices and wearables and data being transmitted. All of that, in my mind, falls under what I call virtual service delivery. And as we will see here in a little bit, the way that state licensure of healthcare professions is set up simply limits the access to that care, and places barriers to innovation in that space. So what do I mean by that? Okay. State licensing is becoming a little more irrelevant now than ever, and or unnecessary, simply because the environment in which we now find ourselves with the internet and technology, it allows clinicians to provide services to patients across the globe, let alone a single country or a single state. So, however, the big problem here is just because clinicians now have the ability to do that, we have the tools, we have the platforms and the software, the devices that allow us to potentially reach patients across our own country, or even, like I said, across the globe. It doesn't necessarily mean that clinicians are legally able to provide those services. You might ask yourself, why is that the case? And the main reason is because most states, specifically now talking about the United States, but I'm assuming, I haven't dug into other countries, but I'm assuming most of them are kind of in the same realm. Most state regulatory agencies here in the U.S. require that the clinician hold an active license in their respective field. So if you're an occupational therapist, an OT license, if you're a physician license, whatever, that you hold your license in your clinical discipline or clinical specialty, quote, in the state or the geographic location where the patient is located to receive those services. What does that mean? It means that if you're a physical therapist in Georgia and you have a patient in Washington State across the country, Washington State requires you to have a license to practice physical therapy in Washington if you're going to see your patient via telehealth. Otherwise, they could potentially sanction you for practicing without a license. Now, I've got a couple thoughts about this we'll share in a minute, but that's the barrier, right? And why is that an issue? Because they can report that to maybe the national board. They can report it to your local state of residence as an issue, and then disciplinary action can be taken against you. So basically, unless you're licensed in that specific state where your patient is, or the patient is receiving services, it's considered, quote unquote, practicing without a license. You can see how problematic this is in a world where email reaches an inbox no matter where you're at. Text message can go anywhere. Secure messaging can go anywhere. Patient platforms and portals allow you to access securely your clinician, access your information, maybe even schedule an appointment or something like that with a clinician virtually, regardless of where you're at location-wise. As long as you have an internet connection, you can interact with your healthcare provider. So you can see the technology allows us to communicate, allows us to have these interactions. Legal requirements or regulatory restrictions prevent us from delivering service. You can say, how is that a problem? It is a potentially big problem on two major areas. The first one I'm going to touch on is just the very basic access to care. Let's say you are you work in some kind of small town in rural Montana. It's 60 miles to your nearest hospital or medical facility, and you have an issue requiring maybe a specialized evaluation from a clinician that holds a specialized certification. Whatever. That's very general, right? So you go to the hospital, you see the general practitioner, and they say you need this specialist. The problem is the only specialist, the closest specialist is, 70 miles away. The problem is the state line is in 68 miles. So now this clinician is in the next state over. They're the closest clinician that can see you that has this specialty for your specific issue. Your option is to travel, right? Or maybe you're too sick, or maybe you don't have the financial resources. Maybe whatever ailment or illness that you have prevents you from making the trip, prevents you from traveling. you're now stuck, right? Maybe there's a chance that you have this super specialized person in the state somewhere that can see you via telehealth. But let's say you can't. Let's say it's something super specialized that maybe only, the Mayo Clinic or John Hopkins or St. Jude Medical Center or something like that has this one specific clinician that can see you, that can treat this disease or this issue, and they're states away. They're across the country. And you reach out to this individual, and they can't see you via telehealth because they don't hold a license in Montana. You can see how this is a problem, right? That's just like low-hanging fruit, how that's a problem. I know that my son a while back has same thing I did when we were born. We have something called bilateral parietal foramina, which is like the parietal bones in our heads have foramina, little holes that have some axillary vessels going through. I think they closed up over time. I don't feel them anymore in my head, but it was an issue for my son. At least they thought it was an issue. They sent him to MRIs. They had him go consult the neurosurgeon, the pediatric neurosurgeon, and I live in Augusta, Georgia. We have the Children's Hospital of Georgia here. It's a big children's hospital. We get patients from across the country come here. We got a lot of specialized services. The neurosurgeon came in and did his evaluation or whatever. Said, come back in a year. I'm pretty sure it's not a big deal, and he left. So, great breather for us. Not a big deal. However, a year goes by. We get a call from CHOG, from the Children's Hospital, saying, oh, Dr. So-and-so, this pediatric neurosurgeon, left. He went somewhere else, some big other hospital, to go pursue some kind of fellowship there. So we're trying to track down a pediatric neurosurgeon to do your follow-up, and we'll reach out to you as soon as we find one. We don't have one yet. And we were like, can we do telehealth with somebody else? Is there somebody you can refer us to? No, not in Georgia anyways. They couldn't find somebody. That was several years ago. We still have not heard back. I think last I heard, they were able to track down somebody that came, pediatric neurosurgeon that came, pediatric neurovascular surgeon is what it was, that came and was there for like 6 months on a temporary assignment so that they could, clear out some of the consults that were on backlog. But they've been having a very difficult time trying to find this individual, find somebody to fill that role. Again, you can see how that's problematic if you live in rural, South Carolina or rural Tennessee or rural Kentucky, where there aren't these big hospital centers that have these specialized. I mean, Augusta's not the biggest city in the world, but it's not the smallest, and we have a very big medical district here. We've got a few major hospitals. We got a VA hospital, medical college. We've got it all here in Augusta on the healthcare side. And it's still difficult to get those like hyper specialized individuals. And yeah, you can say like that's, state regulation or state licensing for healthcare professionals might put barriers for these like one-off, super small, like being struck by lightning incidences. And that's a risk we're willing to take as a society, that, it's becomes harder to find somebody like that or get treatment from a specialist like that, because in the long run, the damage or the potential damage or risk to the public is mitigated by having state licensure. And that's a fair argument we can have. But you can see that it does place real limitations on receiving care, especially in a situation where the individuals that are making the decisions about their own health might be willing to accept some of those risks, right? Given their situation. Sure, I'll take the risk and be seen by this person, even though they don't, quote unquote, hold a license in my state or whatever, because of whatever their healthcare situation or, their risk profile. Without getting too political or anything like that, like that is a contractual agreement between two consenting individuals. You can argue like, what is the state's role in regulating that or limiting that, right? That's neither here nor there. So from a patient access standpoint, you can already see that there's some issues starting to creep up with the way that licensure is required in the geographic location where the patient is receiving care. So that means if there's a patient, again, in a rural town that's far away from maybe a lot of the specialists that they might, or maybe a specialist that they want to see, there's the potential chance that they end up still having to make the drive. We're placing that burden of receiving care still on the patient. Even though the technology exists to eliminate that financial, that economic, that time burden of the travel, right? Maybe even the health risks imposed by taking that trip. And then now it becomes an ethical issue. Is that ethical? I don't know. So that's the first challenge, or the first problem with regulating healthcare professions at each state instead of at a national level. The second one, and I mentioned earlier, revolves around innovation in the healthcare space, specifically technology-enabled care and tech-enabled providers. So I've consulted with a number of startups in the healthcare space that are looking at becoming like technology-driven providers, as opposed to software platforms that are enabling care. Like, these are individuals who or organizations that maybe are founded by clinical experts or clinical practitioners that want to be able to deliver care to areas that have a decreased density of licensed professions, for example. Let's say physical therapists or occupational therapists, because that's what I do, right? I'm an occupational therapist. So in a place where there aren't any occupational therapists, they would like to be able to come in as a tech-enabled provider, a virtual-first provider, to fill the gap, right? And you can do a basic market analysis and see where the density is of all of the occupational physical therapists in the United States, and you can see there's huge swaths in the country that are missing just a number of clinicians. And that part of that might be because population density is there. Part of it is because even if there was a need, those areas can't sustain or can't pay the prices or the salaries for some of these clinicians that would make more money in Atlanta or something like that. So it becomes an issue of, we have the need here, we just don't have the clinicians, and we can't pay the clinicians to travel in. So the next best option would be virtual first, right? These startups, the big challenge that they have is selecting a jurisdiction on which to launch their platform first, because, again, they have to hold licenses in each individual state. So they can't just launch, the teledoc of physical therapy in all 50 states, because they would have to pool licenses for all of their clinicians in all of their states. Now, there's some workarounds for this. Maybe you can get some contractors who are on your platform that are in each state and whatever. But if the goal is to combat a decreasing number of licensed clinicians, because that is a real problem that we're going to have here in the U.S., that the number of clinicians required falls far below what is going to be necessary to maintain and deliver care to an ever-aging population and growing population that has need for these licensed services. And we have less clinicians going into the field, more clinicians leaving because of burnout, you name it. It becomes a challenge. You can't start a tech-enabled or tech-forward or virtual-first platform or provider organization because you're limited by the number of licenses that you can carry, right? So it does limit the innovation. On top of that, not only are you dealing, and this is different from the access piece, but regulation around the tools that clinicians are using, clinical decision-making aids, artificial intelligence-backed tools, data and wearables and things like that. All of these issues are being handled differently by different jurisdictions, which makes it, again, from a standpoint of launching a product or a software or a solution that could potentially decrease barriers to care, decrease the overall cost of delivering services, decrease the manpower or the number of clinicians required to deliver those services, it becomes a much more challenging prospect when you have to navigate 50 different, in the United States anyways, 50 different regulatory bodies, 51 if you're considering Washington, D.C. And it can hamper and limit the innovation in that space, because you might get it worked out for, say, Georgia, but South Carolina is totally different. A very, very simple example of this is things like physical agent modalities for occupational therapists in general. In Georgia, you can graduate with a degree in occupational therapy and you can do physical agent modalities, electrical stimulation, therapeutic ultrasound, laser, you name it. But you need to get an additional certification that requires something like, 36 hours of continuing education and some hands-on practice, and you have to get another form filled out and signed off and notarized that says you can do that. You take, and I've hired clinicians that have done this. I have clinicians that have done this. You take that same clinician and they drive 15 minutes across the river into South Carolina. Same exact experience. Maybe they pulled their licenses. They graduated here in Augusta. They pulled their Georgia license and their South Carolina license on the same day. They can drive over to South Carolina and do physical agent modalities without any additional certification. And that's just a small issue, right? But you can see like the variability. And sometimes, you're talking about 36 hours of continuing education plus advanced certification. Like that's not an insignificant cost to the clinicians themselves practicing. So then you can also make the argument that it's increasing the cost of care, because now you need to compensate these clinicians for this additional certification. So it's one of these things where just even the variability between each states in what is quote unquote within the scope of normal practice is different, which makes it challenging to deliver care in a consistent manner if you're running a national organization. Let's say virtual first or something like that. So a couple of the things that I put in here is that it increases costs. So state licensing, all these different, you have to pull a license in each different state and all that. It increases the cost to deliver care because each one of those states require their own licensure fee and process and time and oversight and you name it. It increases the lead time for clinicians to deliver care because many states still have manually processed application processes. The way they process applications is still, it's not pen and paper in a lot of places, but it's still a manual review for licensure, and that takes time. I know there are some states that are very, very quick, like 24-hour turnaround time for a license, which is awesome. There's some states, Georgia is one of them, where 6 or 8 weeks is not uncommon. Like that is a big time frame to wait. One, for the clinician now who's graduated and who is waiting to start their career, and now they're waiting for licensure. There's economic hardship imposed on this clinician now. It's also increasing the lead time to get these clinicians in the pipeline to start treating patients, which decreases the access to those services. You see a lot of the trickle-down effects of something like this, right? One of the other things I said in here was that it places barriers to innovative companies, I already said this, or providers who look to use technology-enabled care to increase access to many high-need areas like rural, Midwest states and things like that, where specialists may be located hundreds of miles from potential patients. So that's kind of like the overarching principle is that, or the idea here that I've got is that state licensure, if you look at the reason that state licensure was established, it emerged to regulate the quality and the safety of healthcare delivered locally within the states to the citizens of, say, Georgia, for example. The primary purpose is was and still is consumer protection, ensuring that only qualified professionals can practice, right? And that was the idea, that state licensure and regulatory boards would, they're based on the assumption that if they can exclude unqualified or quote unquote unsafe practitioners from the practice pool, it would decrease the chance of an adverse reaction or an injury happening to the public because of, incompetent practice, essentially. State boundaries at the time in the 18th and 19th century made sense because you could only go, travel so far to see a clinician. The odds are you were only going to see a clinician from your state because that's where you were located, and people didn't, the technology wasn't a thing. You couldn't hop on Zoom and talk to a doctor from California. You just couldn't do it if you were in Georgia. Sure, you could, the wealthy might have been able to fly over there or something like that, or drive or travel, but a lot of people couldn't. It just was not outside. It was outside of the realm of the means of most individual. So from a regulatory standpoint, it made sense to do state licensure, and because each state is like from a republic standpoint, each state is autonomous and is able to set its own criteria for the different professions, and the federal government is involved in like interstate commerce and things like that. I think you could make an argument that healthcare now is moving outside of the state realm and moving more towards this interstate commerce realm now, especially with telehealth and virtual service delivery. And maybe there is an argument to establish some sort of national credential system, which is already in place in most every healthcare profession, but we'll dive into that in a bit here. So I did review a few articles when I was thinking about this topic, and I was like, I wonder how effective state licensure is, or what is there research on state licensure versus national credentialing for healthcare professions, and how effective it is at preventing adverse effects on the public, or how effective is it in keeping the public safe, right? Because again, the mandate of licensure is to maintain public safety. There are a couple studies here. One of them is the regulatory gap in digital health and alternative pathways to bridge it. This was an article. When was it published here? This was 2022, so a few years ago, in Health Policy and Technology. And basically, they came to the conclusion that, yes, state regulatory, like having it be based in the states versus nationally, does pose challenges to access and affordability. However, there's a lot of various stakeholders involved, if you would, that make a move challenging. And so the author's conclusion was like, there's no real alternative to regulation. We need to regulate healthcare professions to make sure that people are getting what they, and I get that. From a consumer protection standpoint, you want to make sure that a patient that is receiving care from an orthopedic surgeon is actually getting care from an orthopedic surgeon, and not some guy that hung out a shingle, like stayed at a Holiday Inn Express and now he's an orthopedic surgeon. You need to make sure that that's happening. The challenge is, and they really didn't provide much in the way of solutions to it, but the way we do it now, they were like, it's just going to be how we do it until we figure out a better alternative, right? So what do they say? They say, let's see here. So digital health technologies present new challenges to regulators from both product, so adaptability, variability, variety, etc., as well as industry structural perspectives. So things like changing roles of actors, new delivery models, etc. While they typically fall under the medical device regulatory category, regulators in the United States and Europe do currently not fulfill their statutory role in enforcing market access only to those devices that are safe and efficacious. This is due to a variety of reasons: loopholes in existing regulation, deliberate exemptions from regulation, and lowering of standards, as well as the lack of technical evaluation techniques for some of the technologies employed. We argue, so the authors of this study argue, that this is unlikely to change in the midterm, and we evaluate some alternatives to bridging the problem of the regulatory gap, is what they're calling it. While some show potential and are paths being followed with examples provided, all of them show weaknesses that prevent them from becoming viable alternatives to what we've called now the classical regulatory way of managing it. So regulatory assessments go just beyond establishing the level of safety, yada, yada, yada. So they're basically saying, like, we understand that this is a challenge, but we don't have, this is in 2022, so a few years ago, we don't have any models yet of what it could look like, specifically on the device and the digital side. What's the best way to make sure that a device or a solution is safe and efficacious for patients to use, right? So this is something that's been for the last probably 10 or 15 years coming up, like this idea of telehealth. I remember talking about telehealth. I mentioned this before. When I was at the VA in 2012, telehealth was something that we did out of necessity because we had one VA hospital and 3 CBOCs, or community-based outpatient clinics that were 100 or so miles from the hospital, and they didn't have physical and occupational therapy there. So we would do some telehealth. It was one of those things, like, it made sense to us. We would do telehealth to do mobility assessments or whatever it was. So instead of this patient having to drive potentially 2 or 3 hours to Augusta for a 45-minute appointment, we could do it in telehealth when they were in there to see their PCP or something like that. And I remember having this discussion on the state board, and this was before telehealth became super big in 2020. And what they basically said, what the Attorney General said at the time, the Attorney General's counsel for the board said was, well, basically, as long as you're practicing within your scope of practice and you're licensed in the state of Georgia, you're good. And to us, like, that served our needs because we were in all of the patients that we were seeing were from Georgia. They were in Georgia. They resided in our our geographical area, for lack of a better word, for our hospital. So it wasn't ever anything that we even thought about, I don't think, back then. Like, oh, well, we could go ahead and, telehealth, do a telehealth visit with somebody from a Washington State VA or something like that. That just wasn't a thing, probably because we weren't thinking big enough at the time. But it was something that was there 10 or 15 years ago, the ability to do that. And healthcare licensure and regulatory boards really haven't made a whole lot of progress in the way that we account for and we regulate and we ensure public safety or consumer safety, despite of 10 or 15 years of technological advancement that has made it much more easy and accessible to reach out and have interactions with people that are right, across the country sometimes. So there's that. All right. So another study was quality assurance in healthcare professionals' education, role of accreditation and licensure. This one I thought was pretty. This was just more of a discussion about accreditation and licensure and how it does affect or promote safety in healthcare, patient safety. And it's basically the conclusion from the authors was that regulatory processes need to be built around clear definitions of the goal for each stage of professional development, the current movement towards competency-based education, and the variable durations of medical education. So when we think about healthcare licensure and credentialing and certification and accreditation, this is deeply tied to the preparation of those clinicians, right? You need to ensure one of the big ways that the way that state regulatory agencies ensure that somebody is competent to provide care in their state is they've passed some sort of, they've completed an accredited program or graduated from an accredited program, and they've passed some sort of board examination that demonstrates their competency, right? So this has implications not just for the telehealth and the innovation and the technology, but also like the pipeline of students that are coming into healthcare, especially as educational costs continue to rise and rise and rise, and you have these moves towards what they're calling competency-based education programs, where maybe there's not a lot of quote-unquote book knowledge or academic work. It's more on-the-job training. At its its most simplistic form, that's what it is. I'm not going to dive into that because that could be its own topic, its own podcast episode. But this idea that you don't necessarily need, or do you really need to graduate from an accredited school via the academic sense, or can you get some training like an apprenticeship almost and then end up becoming a licensed clinician? And there's a lot of pushback in this space. It's a very controversial topic. I tend to think probably not. When you look at requirements, the knowledge requirements for healthcare professionals, I feel like is only increasing. It's not getting easier, and more so than just the knowledge that's required, but it's the ability to make clinical decisions. The clinical decision making is becoming more complex given the tools that we have available, the research that we have coming all the time, the ability of a clinician, or what a clinician needs to be able to do is not just know stuff in their head, but really be able to take the pools of data that they have, pull from, and apply that knowledge in a way that's going to be effective for this specific patient in this specific situation. I've said this before countless times. Like that's the value clinicians bring to the table, is our ability to take vast technical knowledge combined with the patient's context and their expectations, their desires, their goals for treatment. Our experience as clinicians after having maybe treated in a specialty for a while, what we know from the clinical research and available tools and treatment options, and kind of meld all those together for a plan that's going to work for this patient, right? Every plan of care for a patient should be more or less bespoke. Yes, there's standard benchmarks, perhaps there are standard protocols for treatment, but every individual is entirely different, which means you can't follow a protocol blindly and expect to get the same outcome every time. Kind of this idea of, I don't know if I have the book here. It's called The End of Average. I can't remember who wrote it, but it's called The End of Average. And the basic premise is that if you take the average of everybody and then you go maybe call it 10 measurements or something like that, and then you go back in that same population from where you got those averages, the odds are that nobody is going to match 2 or 3 of those 10 measurements, right? And basically the author's conclusion is if you're shooting for the average, you're shooting for nobody. And for a long time, healthcare has been working on this idea of averages. But technology, as said this before, is enabling us to become hyper-individualized and hyper-specialized for this specific patient. And that's going to be a great benefit for each patient receiving care. But it does require advanced levels of thinking and aptitude from clinicians that, in my mind, requires proper preparation. And I don't know if this competency-based education models are gonna be up to snuff. I guess we'll see over the next 10 years, and I might be proven wrong, but I think it's something that, in my mind anyways, is probably not something you want to take a gamble on, right? Okay, so that was that study. And let me see. Modernized medical licensing and credentialing. And this is lessons from the pandemic. And I think it was published in, let's see here. This is 2021. The idea here, or the main idea, was that let's just look at the credentialing piece. So the authors say that even if the U.S. had a national physician license at the time that the pandemic hit, hospitals would still have had to invoke their disaster plans to waive usual credentialing processes and immediately employ the physicians needed to staff the hospitals for the pandemic. Credentialing is the process by which the education, training, licensure, registration, and certification, sanctions, as well as work history, including malpractice litigation, are documented and approved by the medical facility where the physician intends to provide care. And not just that, credentialing as a process is really more payer-driven than it is regulatory driven, right? The licensure itself, or the ability to practice healthcare, is managed by, at this point, the state or your national certification agency. Credentialing, this is a pretty generous way of saying that it's driven. The credentialing process is required in order to provide services at this hospital. The reason for that is payment. It's all about the money. The reason you credential a clinician is because Blue Cross Blue Shield, for example, needs to make sure that you're a licensed occupational therapist, for example, before you provide services to their beneficiaries under this practice who's contracted with you, right? And that's what takes a long time, is the credentialing process there for each payer. Because you don't just credential one time. You don't credential a physician with, ABC Hospital. You credential the physician with Medicare, then you credential them with, TRICARE, then you credential them with Blue Cross Blue Shield, then you credential them with Aetna, the Humana, Cigna, all under the contract of ABC Hospital, which is time consuming. And that is not a regulatory issue. That is a payer issue. And it is a different thing altogether, but it's worth understanding too that it's not just, it might sound like I'm picking on regulators, state licensing boards, but this is also a problem in the way that we pay for healthcare and the way that we, again, ensure competency, because these the payers themselves want to make sure that they're paying for they're getting what they're paying for. If they're paying for an orthopedic surgeon, they want to know that an orthopedic surgeon is actually providing the care and not somebody that's calling themselves an orthopedic surgeon. So you can see how complex this is. Now, in that piece, I might say, is a potential solution, right? So how do we streamline regulation for healthcare providers so that access is not an issue, so that we can ensure competency, so that we can ensure that patients are getting what they're paying for, that we can ensure payers are getting what they're paying for, that we can ensure that the public is made safe? Well, probably the lowest hanging fruit here is like a national credentialing system. So, or broad-based licensure and reciprocity. Now, I know in various disciplines, you have licensure compacts coming up. I've been involved in some of these discussions about licensure compacts because of my work with the national board. I'm not going to disclose anything super crazy here, but there are disciplines that have done have gotten licensure compact legislation passed in most of the states for their disciplines. They've stood up the compact. They've got the pieces in place, the database built. They've got, because the regulatory issues like what's the word I'm thinking for? Disciplinary action and stuff like that needs to be housed in a database so that all the members can see, whatever. That all costs a lot of time, a lot of energy, a lot of money, a lot of manpower, and a lot of time to get those pieces of legislation not just approved and signed in that state, but then incorporated into the greater licensure compact. To my knowledge, most all of those licensure compacts are not financially viable. They're not able to stand up on their own without great cash infusion from the state or from the national professional associations and or state agencies kind of propping them up. Why is that an issue? Because you can't do it for every single healthcare profession. You can't invest millions and millions of dollars into state licensure compacts. And the reason that they're not financially sustainable is because the demand isn't there. You think, okay, you're like, what clinician wouldn't want to be able to practice in all 50 states with one license? Well, we all would love to do that. The next question is where it falls apart. It's how many licensed clinicians are willing to spend an extra, 25, even if it's 10 or 15 bucks per state that they want to practice in. Well, now you've got clinicians that are like, I don't really need a compact license because I'd like to be able to provide telehealth to somebody across the country, but I'm not going to pull a compact license or pay the extra fee to be able to do that in every state. I'm just not going to do it. It will help a small handful of clinicians that practice in maybe like a tri-state area or some place where you're close geographically to multiple jurisdictions, and it makes sense because maybe you're going to do home health or telehealth or something for those. It's still a small geographic region, so it doesn't really make sense as a viable long-term solution. So in my mind, something like a national credentialing system works. Or national accreditation system or certification system works and would require very, very little from a regulatory standpoint. I mean, state license boards might not like this, but you could just, the State Practice Act could be amended to just say practice within the scope of practice by X, national board for whatever. And as long as you hold that certification, you can practice under this, in this state or this jurisdiction. I think that would be pretty easy to do. The other piece there is that I mentioned the credentialing piece is a payer function, not a regulatory function. And that could be a viable alternative. Like, let's say you get credentialed by Blue Cross Blue Shield. Arguably, Blue Cross Blue Shield has a greater incentive to ensure that their clinicians, that the clinicians that they contract and that they pay for are competent, are not going to injure their beneficiaries, are going to provide the arguably the highest quality care than a state regulatory agency is incentivized to do. Because for payers, if you don't get good clinicians in your network, arguably you're losing to a different payer or something like that. So there's going to be competition among the paying organizations, the payers, to ensure that the people that they're paying for, the clinicians for whose services they are paying, are actually competent, capable, and safe practitioners. And then you get this self-regulating system where, if you have a malpractice issue twice with Blue Cross Blue Shield and they cut you out of your network, well, now you've essentially been cut out of practicing in that discipline for that payer, which might mean subsequent payers cut you off, which might mean, hospital systems don't hire you anymore, or national provider organizations don't hire you anymore. And it essentially can remove, quote unquote, those incompetent clinicians from the system without having the burden or the added bureaucracy of like a state regulatory process for doing that, right? In some cases or some manner, kind of letting the free market do it. Again, I think the incentives are aligned better there anyways. Not that we want to start getting into that piece, but those are just some thoughts that I have. I know I feel like I've rambled on long enough about this idea of state licensure. In my mind, just to recap, state licensure is it's a 19th century solution to a 21st century problem. We do need to think about a way to increase access, to increase the ability of people to provide care, clinicians to provide care across geographic locations for patients and consumers to be able to access that care, and to make sure that people are safe when they're doing it. I think, like I said, a national licensing or a national certification program or system seems to be the way to go. But I don't know. Let me know in an email or something what you think about state licenses. Is it something that we should keep doing? Is it something we need to rethink? Should we scrap the whole thing altogether? I'd love to know your thoughts. So that's it for this week. If you like the show, head on over to iTunes, leave us a rating and review. It helps people find the show. If you want to learn more about me or connect with me, RafiSalazar.com is the way to do it. If you run a healthcare organization and you're looking for a way to differentiate your services, check out the Positioning Alignment Workshop, the Healthcare Positioning Alignment Workshop at positioning.rehabupracticesolutions.com. That's positioning.rehabupracticesolutions.com. Until the next time, folks, be safe, be healthy. I will talk to you then.